All of us would have been told to wake up during long lectures. But have you ever wondered if there's something more to it? Obstructive sleep apnea is a type of sleep related disorder characterized by pauses in breathing or shallow breaths during sleep due to recurrent episodes of upper airway obstruction. There are three forms: central, obstructive, and complex. The risk factors are obesity, the patient's gender, race, family history, various anatomic physiological factors, and also social and behavioral factors. The causes can be nasal obstruction, a thick soft palate, retroposition mandible, a redundant pharyngeal tissues, large tonsil, large tongue, and etc. The management of obstructive sleep apnea can be divided into medical, surgical, and non-surgical. Under medical, you have weight loss, nasal obstruction treatment, smoking cessation, CPAP, which is continuous positive airway pressure. In non-surgical, you have different oral appliances. And in surgical, under soft tissue, according to the level of obstruction, you have different procedures. For example, uvulopalatopharyngoplasty. And in skeletal, you have maxillomandibular advancement. This is the first case that I'm going to present, which is of a 16-year-old male who came to the Department of Oral and Maxillofacial Surgery with the chief complaint of reduced mouth opening, loud snoring, excessive daytime somnolence, morning headaches, and inability to concentrate. He had been treated for bilateral TMJ ankylosis with costochondral grafts 9 years ago. The patient presented with a retroposition mandible, convex profile, restricted mouth opening, and a severe malocclusion. The patient was treated with bilateral extraoral unifocal distractors in place, and post-extraction, the profile of the patient had improved, the malocclusion had improved, and the pharyngeal airway space had increased. So after 20 months of orthodontic treatment, the patient's occlusion was brought into ideal occlusion and the patient was satisfied. 3 years of follow-up, the patient had no complaints. Then in the year 2019, the patient came with the same chief complaint of loud snoring, excessive daytime somnolence, and morning headaches. The patient's clinical findings were reduced pharyngeal airway, a convex profile, relapse in occlusion, retrognathic mandible, class 2 skeletal relation, and lip incompetence. The treatment objectives would be to increase the pharyngeal airway, improve profile, ideal positioning of the mandible, achieve ideal occlusion, achieve class 1 skeletal relation, and achieve lip competence. The surgical plan is maxillomandibular advancement, Lefort 1 osteotomy, vertical ramus osteotomy, along with iliac bone graft and genioplasty. An intraoral approach, Lefort 1 osteotomy cut was made. An extraoral approach, bilateral vertical ramus osteotomy was done. Then the iliac graft was harvested and positioned in the required position. Post-op, the patient had an improved profile. The occlusion was brought back to the ideal occlusion, and you can appreciate the osteotomy cuts in the OPG. As you can see, in the pre-op, designated by the red, has a restricted, reduced pharyngeal airway. In the post-op, designated by the green, has an increased and significant improved airway. Post-op after 1 month and after 4 months where the swelling has reduced. The timeline of this patient has been before distraction, post-ortho, post-surgical, where the improvement has been significantly seen. The case 2 that I'm going to present is of a 24-year-old man who came to the Department of Oral Maxillofacial Surgery with the chief complaint of restricted mouth opening, loud snoring, excessive daytime somnolence, and morning headaches. The patient had a convex profile, retropositioned mandible, and a reduced pharyngeal airway space. The treatment objective would be to increase the pharyngeal airway, improve profile, improve mandible position, and maintain ideal occlusion. The surgical plan is to place bilateral intraoral unifocal distractors. An extraoral approach, a submandibular incision, and the placement of the intraoral unifocal distractors, and the wound was closed. Post-op, the position of the mandible was improved and the pharyngeal airway had increased. The bilateral intraoral unifocal distractors for this patient had a rhythm of 0.55 mm advancement per day with a rate of morning and evening for 50 days and 25 of mandibular advancement was done in total. Post-op, in the first picture, you can appreciate the osteotomy cuts, the space, then the distraction presented by the distractors, and the new bone formation. In conclusion, OSA can increase the risk of heart failures, hypertension, stroke, diabetes, liver diseases. So don't take heavy snows lightly and get it checked promptly. These are my references. Thank you.